Hello and welcome to Easy Learning with Dr. Salman. Next, pathogenesis. Leishmania donovani causes visceral leishmaniasis or kala azar. Kala azar is a reticuloendotheliosis resulting from the invasion of reticuloendothelial system by Leishmania donovani. The parasitized macrophages disseminate the infection to all parts of the body. Three major surface membrane proteins of Leishmania, which are first GP63, second lipophosphogycan, also known as LPG, and third glycosyl phosphatidylinosytols, GPIs, which give protection against hydrolytic enzymes of macrophage phagolysosome. The pathogenic lesions are observed in the following organs: spleen, bone marrow, lymph nodes, and the liver. In the spleen, liver and bone marrow particularly, the mastigotes multiply enormously in the fixed macrophages to produce a blockade of the reticuloendothelial system. This leads to a marked proliferation and destruction of reticuloendothelial tissue in these organs. First, spleen. The spleen is the most affected organ. It is grossly enlarged and the capsule is thickened due to perisplenitis. Spleen is soft and friable and cuts easily due to absence of fibrosis. The cut section is red or chocolate in color due to the dilated and engorged vascular spaces. The trabeculae are thin and atrophic. Microscopically, the reticulum cells are greatly increased in numbers and are loaded with LD, that is Leishman-Donovan bodies. Lymphocytic infiltration is scanty, but plasma cells are numerous. Next, liver. The liver is enlarged. The Kupffer cells and vascular endothelial cells are heavily parasitized, but hepatocytes are not affected. Liver function is therefore not seriously affected, although prothrombin production is commonly decreased. The sinusoidal capillaries are dilated and engorged. Some degree of fatty degeneration is seen. The cut surface may show a nutmeg appearance. Then bone marrow. The bone marrow is heavily infiltrated with parasitized macrophages which may crowd the hematopoietic tissues. Then lymph nodes. Peripheral lymph nodes and lymphoid tissues of the nasopharynx and intestine are hypertrophic, although this is not seen in Indian cases. So these were the pathogenic lesions produced by the parasite. Then anemia in kala azar. Severe anemia with hemoglobin levels of 5 to 10 grams per 100 ml of blood may occur in kala azar as a result of infiltration of the bone marrow as well as by the increased destruction of erythrocytes due to hypersplenism. Autoantibodies to red cells may contribute to hemolysis. Leukopenia with marked neutropenia and thrombocytopenia are frequently seen. Antibodies against white blood cells, WBCs, and platelets suggest an autoimmune basis for the pancytopenia observed in kala azar. The causes of anemia in kala azar are: first, splenic sequestration of red blood cells, RBCs; second, decreased erythropoiesis due to replacement of bone marrow with parasitized macrophages; third, autoimmune hemolysis; fourth, hemorrhage; and fifth, marrow suppression by cytokines. Next, pathogenesis and immune response. Leishmania infection and multiplication of the parasite is under the control of the host immune system. When Th2 response, that is the helper cells type 2 of immune system, is dominant in a susceptible individual, the defense against intracellular parasites becomes inefficient. As a result, the intracellular parasite establishes infection. The infected macrophages are initially activated but not sufficiently to kill the intracellular organisms. However, the ineffective activation of macrophages is adequate for causing inflammation. Eventually, the macrophages are destroyed, thus the disease progresses in a susceptible individual. In contrast, with adequate resistance to Leishmania, where the Th1 response, that is the helper T cells type 1 of the immune system, is dominant, there is increased capacity of the infected macrophages to eliminate the intracellular parasites, which is related to secretion of interferon gamma by activated Th1 type cells, also called as IFN gamma. This completes the pathogenesis. Next, clinical features. The incubation period is 3 to 6 months, which may exceed 1 and sometimes 2 years. The symptoms are first pyrexia, that is fever. This is an early symptom. The fever may be continuous or remittent in type, which becomes intermittent at a later stage. And in 20% cases, it shows a double rise in 24 hours. Second, splenic enlargement. This is one of the most striking features where the organ progressively enlarges. With the progress of the disease, it extends several inches below the costal margin. Third, liver. It is enlarged but not as much as the spleen. Fourth, lymphadenopathy. This is common in most endemic areas except Indian subcontinent. Then the general features. There is no malaise or apathy and the patient may be quite unaware of the high fever. The appetite is good with a clean, moist tongue. Epistaxis may be a presenting symptom. In fully developed case, emaciation and anemia become noticeable. Cachexia with marked anemia, emaciation and loss of pet is seen. Then the skin changes. These are common and often seen on the face, hands, feet and abdomen. The local Indian name of Kala Azar, which means black sickness, is a reference to the pigmented, darkened color which the patient's skin develops. The nature of the skin becomes dry, rough and harsh and is often pigmented or darkened. The hair tends to be brittle and falls out. If this is left untreated, 75 to 95% of patients die within a period of 2 years. Death in Kala Azar is always due to some complications like amoebic or bacillary dysentery, pneumonia, pulmonary tuberculosis and other septic infections. Next, hematological abnormalities. Anemia is most always present and is usually severe. Then leukopenia, that is decreased WBC count. Then thrombocytopenia, decreased platelet count, is associated with epistaxis, gum bleeding, gastrointestinal, GI bleeding. Then ascites and edema may occur due to hypoalbuminemia. Renal involvement is also common. In late stage of human immunodeficiency virus, HIV infection, visceral leishmaniasis can present as opportunistic infection. HIV co-infection rate is 5% in India and 20% in African countries. Secondary infections such as herpes, measles, pneumonia, tuberculosis, bacillary dysentery may occur. Most untreated patients die in about 2 years due to some intercurrent disease such as dysentery, diarrhea and tuberculosis. Then the condition post-Kala Azar dermal leishmaniasis or PKDL. About 3 to 10% cases of patients of visceral leishmaniasis in endemic areas develop PKDL, post-Kala Azar dermal leishmaniasis, about a year or two after recovery from the systemic illness. Post-Kala Azar dermal leishmaniasis is seen mainly in India and East Africa and not seen elsewhere. The Indian and African diseases differ in several aspects, which is discussed later. The post-Kala Azar dermal leishmaniasis is a non-ulcerative lesion of skin. The lesions are of 3 types. First, depigmented or hypopigmented macules. Second, erythematous patches. Third, nodular lesion. The types: first, depigmented or hypopigmented macules. These commonly appear on the face, the trunk and the extremities and resemble tuberculoid leprosy. Second, erythematous patches. These are distributed on the face in a butterfly distribution. Third, nodular lesion. Both of the earlier mentioned lesions may develop into painless yellowish pink non-ulcerating granulomatous nodules. The parasite can be demonstrated in the lesions. Next, differences between post-Kala Azar dermal leishmaniasis of India and East Africa. Characteristics: first, incidence. It is 5% in Indian cases whereas 50% in East African cases. Then time interval between visceral leishmaniasis and post-Kala Azar dermal leishmaniasis. In India, it occurs after visceral leishmaniasis and may take 3 to 5 years. In East Africa, it occurs during visceral leishmaniasis. Then age group affected. In India, it may occur at any age. In East Africa, it is seen mostly in children. Then appearance of rash. In Indian cases, rashes appear after visceral leishmaniasis. In East African cases, rashes may appear during visceral leishmaniasis. Then spontaneous cure. In Indian cases, it is not seen, whereas in East African cases, spontaneous cure occurs. Next, immunity. The immune response in visceral visceral leishmaniasis is very complex. There is increased production of pro-inflammatory cytokines and chemokines, interleukin-10, IL-10, and transforming growth factor beta, TGF-beta, are the dominant cytokines. The most important immunological feature in Kala Azar is the marked suppression of cell-mediated immunity to leishmanial antigens. This makes unrestricted intracellular multiplication of the parasite possible. Cellular responses to tuberculin and other antigens are also suppressed and may be regained some 6 weeks after recovery from the disease. In contrast, there is an overproduction of immunoglobulins, both specific anti-leishmanial antibodies as well as non-specific polyclonal IgG and IgM. Circulating immune complexes are demonstrable in serum. So these are the clinical features of Leishmania donovani. If you wish to see more of such videos, do comment below. And don't forget to like, share and subscribe to my channel. Also, press the bell icon for early notification of my new videos.